Okay. Before I get started, I always like to distinguish the different ways we can understand tobacco products. So when I refer to tobacco throughout today's presentation, I'm going to be referring to commercial tobacco that's manufactured by the tobacco industry, and not tobacco that is used for sacred or ceremonial purposes by some American Indian communities. And there are a variety of commercial tobacco products on the market today, but I'll be focusing primarily on combustible cigarette smoking because it's the number one product used by justice-involved individuals, and it is the most lethal. So my objectives for you over the next 40 or so minutes are to understand tobacco use disparities in the justice-involved population. To describe the benefits of tobacco cessation for behavioral health and recovery, and then to identify evidence-based treatments, resources, and practical strategies to support recovery from tobacco dependence. But first, I have a poll, and if I can pull up this first poll to just give a sense of when you think about substance use assessment and treatment in correctional settings and community corrections, where does tobacco use rank as a priority? Okay, so we've got majority of folks. And so if you can see, we're kind of split in thirds with a third of people saying it's important but secondary to the other substance, about another third saying it's a low priority, and a little over a third saying it's rarely discussed. Thank you. That is helpful. So first, I'd like to start off with a success story, which is that since the 1960s, we have continued to see combustible smoking decline in the general US population from where it was at around 45% in the 1960s to being down to now 11.5% in 2021. And this is really nothing short of a public health victory. However, despite this progress, cigarette smoking and secondhand smoke exposure still claim nearly 500,000 lives in the United States every year. In Wisconsin, as in the country, we have also seen declines in tobacco use, with current smoking rates around 13%, 12.5%. However, despite these declines, tobacco use remains disproportionately high in certain populations. And these groups are, socioeconomically disadvantaged communities, certain racial and ethnic groups like American Indians, African Americans, individuals with lower education, the LGBTQ plus population, and individuals with co-occurring mental health and substance use disorders. So smoking, it seems to be concentrated and disproportionately impacting certain groups today. One population we rarely discuss when talking about tobacco use disparities is people involved in the criminal legal system. And this encompasses a lot of people. There are 5.6 million Americans in the criminal legal system. Between 50 and 80% of this population smokes cigarettes, and that's 4 to 5 times higher than the general population. When we look at data collected in Wisconsin at a correctional facility that asked about ever lifetime use of cigarettes, data collected over this 9-year period showed that respondents reported between 85 to 91% of individuals said that they had ever smoked. This very high smoking prevalence remained unchanged over that 9-year period compared to the downward trend we were seeing in smoking in the general population in Wisconsin. And so, what this shows us is the disparities in smoking between those with justice involvement and those without is actually worsening over time. The high prevalence of smoking in the justice-involved population is in part due to this population being made up of groups that are disproportionately impacted by tobacco use, and individuals with behavioral health conditions is one such group. For example, about 25% of adults live with a behavioral health condition, but at least 50% of those in jail or prison report having a substance use or mental health need. Smoking related disparities are particularly relevant to this group. Number one, because of the prevalence of smoking being very high, but also smoking is a leading cause of death for people with co-occurring conditions. About half of the deaths among people in substance use treatment are tobacco related, and individuals with serious mental illness on average die around 25 years earlier compared to those without a serious mental illness and who do not smoke. The toll of tobacco use is also burdensome for the justice-involved population as a whole because people entering and leaving incarceration experience higher prevalence of chronic health conditions and communicable diseases. And I know that the labels on this slide are a little bit dated. We no longer use that term prisoners. But what this just highlights is that individuals are already in poor health oftentimes when they're intersecting with our prisons and jails, and continued tobacco use after release worsens those health outcomes for a population that often faces challenges accessing healthcare after they are released. So next, I'd like to describe the benefits of tobacco cessation to behavioral health and recovery. But first, let's address why tobacco use isn't routinely assessed or treated in behavioral healthcare and correctional healthcare, and 3 common misperceptions about addressing tobacco use. The first one is the people in my care don't want to address their tobacco use. The second is that smoking isn't related to public safety or reducing risk of reoffending or reentry success. And the third is tobacco use is a low priority compared to other substances which have a more immediate risk to health. So this first one about individuals not being interested in quitting is one of the biggest misconceptions. And in reality, research consistently shows that when you ask and provide a little education about the benefits of quitting and offer support, between 44 to 80% of people engaged in substance use disorder treatment say, yeah, I'd be interested in making some changes or quitting. And nearly half of people in substance use treatment are trying to quit each year. We see a similar pattern among people who are incarcerated, that these are individuals who are reporting a desire to remain abstinent following release from prison and are receptive to smoking relapse prevention support prior to release. And that is data we collected interviewing some folks in Wisconsin correctional facilities around the time that the smoke-free ban was implemented in correctional facilities in Wisconsin. The second misperception is that tobacco use isn't directly tied to public safety risk of reoffending or reentry success. And to address this, I first want to look at this definition of recovery as defined by SAMHSA. Recovery is a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their potential. And if the goals of correctional healthcare align with these goals, then recovery is much broader than just helping people remain abstinent from substance use. It's about building the capacity to live successfully in the community. And tobacco cessation can play an important role in that. Even though tobacco use in and of itself is not a criminogenic risk factor, it is a factor tied to health, wellness, recovery, and social drivers of health like employment, housing, and financial independence. And these are factors that we know impact one's ability to function successfully in society and benefit from rehabilitative interventions. So let's dig a little bit deeper into how tobacco use connects to health, home, and purpose. First, health is a prerequisite for living a self-directed life and being able to reach one's potential. And we obviously know that there are many benefits to quitting smoking to health and overall wellness and supporting, physical, mental health, and substance use disorder recovery. In terms of the home, many facilities that individuals are releasing to in the community, whether it be transitional housing, supportive housing, recovery housing, have smoke-free policies. And so remaining tobacco-free after release helps individuals comply with those housing requirements and maintain stable living conditions. In terms of purpose, quitting tobacco can be empowering, an empowering, self-directed choice that aligns with other positive life changes. It supports financial stability by reducing the cost of purchasing tobacco. Individuals can free up resources for essentials like food, transportation, or job training. And that, in fact, is one of the primary motivational drivers that we hear about from case managers working with individuals during release, is that financial piece that drives them to make changes. And then lastly, the community. Tobacco use can create social barriers, particularly in environments where smoking is restricted. Quitting can foster stronger connection with family, peers, pro-social networks, reinforcing positive social ties and community engagement. To the last misperception that tobacco use is a lower priority because it doesn't immediately pose a risk to health. That last part is true. The harms from tobacco use actually accrue over time compared to other substances like alcohol or opioids that are a more immediate risk to health. However, in the long run, neglecting to address tobacco use robs a lot of life and quality of life from people with behavioral health conditions. So, if you recall, I mentioned that about 500,000 people die each year from tobacco related diseases, and more than half of those deaths occur in people with behavioral health conditions. There are short-term consequences of neglecting tobacco use and substance use recovery. So nicotine is commonly co-used with other substances of use and misuse. This isn't a coincidence. The shared biological underpinnings that support co-use of nicotine with other substances is well established. For example, smoking is a primary risk factor for opioid addiction because nicotine primes the brain's reward system, making it more responsive to the effects of opioids. As a result, when someone smokes and is trying to abstain from opioids, they're going to experience intense cravings for opioids because nicotine has reactivated those drug-seeking receptors. And this is a primary reason why smoking can lead to relapse to alcohol and other substance use. In fact, the more you smoke, the greater the likelihood of relapsing and doing so more quickly. There are also short-term consequences of continuing smoking to mental health as well. So we know there are chemicals in tobacco smoke that interact with many psychotropic medications and speed up their clearance or metabolism by the body. And so individuals need to be on higher doses of those medications to get the same effectiveness. Medication side effects are a significant quality of life factor for many individuals with mental health conditions. We know these side effects impact adherence and impact treatment effectiveness and outcomes. And these effects of smoking can lead to greater depressive symptoms, greater likelihood of psychiatric hospitalizations, and increased risk of suicidal behavior for individuals with severe mental illness. So let's take a look at the benefits of quitting smoking to substance use disorder and mental health recovery. Learning to quit smoking can positively influence drug and alcohol recovery by providing effective skills and techniques to abstain from all substances, as well as the sense of mastery. So a lot of times, individuals will report that nicotine was the most difficult substance for them to quit. Studies show that quitting smoking alongside alcohol and other drugs actually improves long-term abstinence from all substances by about 25%. So the neurochemical and behavioral links that underpin co-use of nicotine with other substances is a key reason why treating smoking is an important part of recovery. Providing smoking cessation interventions during addictions treatments appear to actually enhance rather than compromise long-term recovery. As far as the benefits to mental health, beyond the initial withdrawal symptoms that individuals may experience when they quit smoking, smokers who quit, um, they experience reduced levels of depression, anxiety, and stress, as well as improved positive mood and quality of life compared to individuals who don't quit and have mental health conditions. So lastly, I'll just share that substance dependence is one of the greatest drivers of dynamic needs in correctional care. And so if we're still seeking to understand how tobacco is connected to the many goals of correctional healthcare, I'll just underscore this. Concurrently addressing smoking can improve responsivity to an engagement in substance use disorder treatment. And we've seen this most often in studies of people in opioid use disorder treatment as well as alcohol use disorder treatment. So I have some of the findings of studies looking at people who quit smoking and were in opioid use disorder treatment and what the outcomes of that were for them. And these individuals reported lower relapse rates, improved treatment retention and long-term abstinence, reduced cue-induced craving and drug-seeking behavior, and overall enhanced physical and mental health, which we know supports recovery. So now moving on to our last objective, which is to look at those treatments, resources, and practical strategies to support recovery from tobacco dependence. First, I'd like to just acknowledge a really positive step that the Department of Corrections took in 2006 to implement smoke-free policies. This was a positive step forward because it protected the health of people living and working in prisons and jails from secondhand smoke exposure. What the literature has told us, though, about smoke-free policies is that policies alone don't equate to long-term recovery from nicotine dependence for those who have a history of smoking and are coming into these facilities. And so when we have a policy, but we don't have a systematic or universal treatment for tobacco use disorders provided, for example, nicotine withdrawal management upon entry or relapse prevention upon release, the result of that is that a very high percentage of people actually relapse back to smoking, and that estimate is as high as 90%. And a primary driver of this relapse is just the many stressors that individuals experience during reentry, from finding housing, employment, accessing healthcare, etc. And because they haven't had any discussions about positive coping mechanisms, the thing they fall back on is smoking as a coping mechanism for stress. So something that the American Society of Addiction Medicine and SAMHSA has discussed in their guidelines for treating co-occurring conditions is this notion of it's important to provide recovery-oriented environments to support treatment and vice versa. These two things go hand in hand to yield more successful outcomes, and that's true for nicotine addiction as well. Tobacco treatment and tobacco policies really complement each other and go hand in hand. So, what are evidence-based tobacco treatments? For those who do assessments and SUD planning, some of these um, interventions will look familiar because they're the same as medication-assisted treatment. So tobacco dependence is treated through a combination of behavioral interventions and medications. And individual, group, and telephone counseling are effective. Their effectiveness increases with treatment intensity. So the more time spent counseling, the more likely people are to benefit and remain abstinent in the long term. The same behavioral strategies that are used in other substance use disorder treatment are effective for tobacco dependence. So motivational interventions that get people to think about the pros and cons of changing their smoking behavior versus not changing it. Cognitive behavioral therapy that gets them to identify common triggers to smoke, coping mechanisms, support systems to help with behavior change are all effective skills to utilize to help people who have a history of smoking. And contingency management is a strategy that has been found to be effective as well. There are 7 FDA-approved medications to help relieve nicotine withdrawal and strong cravings, and they can reliably increase long-term abstinence. There are 5 nicotine replacement therapy options and 2 non-nicotine medications, varenicline and bupropion. This is a lot to remember, so we usually just narrow it down to these 2 options which have been found to be the most effective. So for individuals who have moderate to severe nicotine dependence, a combination of the patch and the gum or one of the faster acting products, the gum or the lozenge, have been effective, more effective than just prescribing the patch alone or the gum alone. And then varenicline has been found to be the most effective non-nicotine product on the market. So just wanted to introduce you to what those medications are that are available. And for those individuals who are releasing and are eligible for Medicaid, uh, all of the medications I just mentioned are covered by Medicaid. This includes combination therapy, so for example, the patch with the gum. And so we know that cost is a significant barrier to engaging in some of these treatments. And this is an underutilized benefit, so it's important that this just be more broadly known that individuals can tap into this benefit if they have Medicaid and receive free medications from a provider who's Medicaid eligible. Counseling is also a covered service as well. So I wanted to address a community resource that would be an excellent resource to connect individuals who are leaving these facilities because the Wisconsin Tobacco Quitline is a free resource for anyone in Wisconsin that is interested in support to, either maintain abstinence or if they have gone back to smoking or other tobacco product use to quit again. The Quitline offers free medications, the nicotine patch, gum or lozenge, and there are the standard service is 2 weeks of these medications. So oftentimes we know individuals are not immediately connecting with their primary care provider or any kind of provider in the community right away. So this is a great resource that could be a nice stopgap to connect people to medication, to that NRT. They can receive these medications within a couple of days of calling the Quitline. Um, the counseling services are really geared towards people of all walks of life. If they have behavioral health challenges, the coaches are aptly trained to address that and help them develop a quit plan, address triggers, and enhance their coping skills. The services are provided over the phone, over the web, or through text messages, and they're for individuals who speak any language. There's a separate line for Spanish speakers that will connect them directly to Spanish speaking coaches. The Quitline also has a separate program for American Indians, so that number they can call and receive an enhanced benefit, so additional calls and medication through that program if they identify as American Indian. And then for the juvenile and young adult population that wants to quit vaping, there is a vaping cessation program through Live Vape Free that provides digital cessation support. And again, anyone who is accessing these Quitline services and is 18 years older can receive free medications through the Quitline. So those treatments and that community resource, the quit line, can be provided to individuals. But the clinical practice guidelines really talks about this overall approach called the 5 A's, which systematically integrates screening and providing treatment into the existing services that your facility provides. And it starts with that screening question, providing brief advice or education on the benefits of quitting, assessing readiness to make changes, and linking people up with support based on their readiness, and then arranging for follow-up to prevent or address relapse. So the 5 A's is a recommended approach for providing systematic screening and treatment of tobacco use. So in 2024, um, my colleagues and I published an article that really combined the recommendations of the clinical practice guidelines, which is on the left, with the recommendations from ASAM on how to integrate tobacco use disorder interventions and addiction treatment, and tailored those recommendations specifically for correctional settings. And the recommendations that we made were that at prison or jail intake, to screen everyone for tobacco use, to assess their level of dependence, and to integrate the screening question for tobacco use into this assessment that you're already using to identify a history of substance use. So we don't need to reinvent the wheel and develop a separate screening tool for tobacco use. It can be integrated into the one you're already using. During incarceration, we recommended providing nicotine withdrawal medication management because nearly all daily tobacco users have nicotine dependence and will go through withdrawal. And then we echoed ASAM's recommendation to go beyond just managing withdrawal to providing actual treatment, which would include um, that standard of treatment similar to MAT, a medication and counseling combination. And we know tobacco treatment is sometimes viewed as like a health and wellness service. Sometimes it's viewed as an addiction treatment service. It fits well into either category. So however it best fits into the services you provide. At reentry, we really encourage there to be involvement of the treatment specialist or social worker to integrate tobacco relapse prevention into the release plan. So if you're already identifying triggers around other substance use, incorporating, nicotine into that conversation, and then connecting individuals with uh, treatment support and that resource, the quit line, after they're released, because that will ensure that they can get access to NRT medication to help prevent relapse after they're released. So I've hopefully shared some things that have sparked some changes in the way you think about this issue. When you go back to your facility and have conversations about this issue, just know that you don't have to make changes in your workflow or your services to integrate screening and treatment for tobacco use by yourself. There is a team of individuals at UW-CTRI that offers support to a variety of healthcare organizations, behavioral health organizations. And in fact, we've been working with reentry organizations for the past 5 years on integrating screening and treatment into their case management services, so it can be done. So these are the three outreach specialists and the regions that they cover. I'm in Milwaukee and I cover that yellow shaded region. And so they are resources to you if you'd like to improve upon in some way how you're addressing tobacco use. And our approach has really been to just work with the facility on understanding what their current practices are, what their current needs or barriers are, and sometimes it's a matter of just training staff. And then we always look to see how tobacco screening and treatment can be integrated into the existing services that are provided. because that's what in the long run will be sustainable. And we provide a lot of resources and training and support to ensure that staff are knowledgeable and comfortable to address tobacco use and understand the importance of addressing tobacco use so that you can provide that education to the individuals you serve. We also have a website that is um, focused on supporting behavioral health providers with addressing tobacco use. It's called helpusquit.org. And two of the resources I wanted to point out on this website were our toolkits and our training opportunities. So we have toolkits. The one that might be of interest because facilities are already smoke-free is the toolkit on tobacco treatment integration. So this is a toolkit that has a lot of fact sheets, tools, case studies, and examples and really walks you through how screening and treatment can be integrated. And it's for clinicians, administrators, and it even has resources directly for residents or clients. The training resources I wanted to highlight, we have webinars that directly address the myths around addressing tobacco treatment to kind of help staff understand and buy into the rationale for addressing tobacco use. Um, we also have a bucket approach training, which is our most utilized training on the website, and it's really targeted to behavioral health providers. It provides tailored skills and competency to not only screen for tobacco use, but provide readiness-based assessments for individuals who smoke and have mental health and substance use challenges. This is a training that can be taken at your leisure. All of these trainings can be taken at your leisure, and this one provides 8.25 hours of free continuing education credit. And we also have a training for systems change that has panel discussions from various Wisconsin um, residential treatment programs. So we're almost at the end here. I would like to pull up our last poll and stop sharing that other one. Okay, maybe sharing results, stop sharing. Let's see. All right, it's not, oh, back. Let's try that one. Okay, now here we go. So this last poll asks, after today's presentation, what is one area where your organization has the greatest opportunity to improve how it addresses tobacco use? I'll give you a couple of seconds to answer that question. Okay, we have majority of folks have now entered in a response, so I'm going to end the poll and share the results. And it looks like we have the majority of individuals that have identified staff education and training as something that they would like to pursue, followed by better community referrals and probably thinking specifically about that quitline resource, followed by screening everyone for tobacco use and then providing nicotine withdrawal treatment. Thanks for answering that. So I'm going to next introduce our guest speaker. So we are fortunate to have someone here who is able to talk about what implementation of tobacco screening and treatment looks like. And she is someone who does this work every day. So you've heard me talk about the evidence, the resources, and what the outreach program does. And now we get to hear from Kari Ives, who is a social worker within the Wisconsin Department of Corrections. And Kari, is there anything else you would like us to know about yourself in your introduction?
Um, I guess I just say I think I got involved with you guys probably in 2011, and we've built on a great relationship and how we implemented this here at Chippewa Valley Correctional Treatment Facility.
Yeah, that's great. Yeah, so we have been partnering with Kari for a long time, and she has been a real champion for addressing tobacco use and really leading the charge with helping support people who have a history of tobacco use. So, with that, let's segue into our first question. Carrie, how do you support individuals with a history of tobacco use?
So one thing that we had implemented is anybody that comes in through our facility. Oh, my mic's kind of muffled. Okay.
I can hear you.
Okay. Um, and so I have a lot of, we have the screens on the TV advertising our nicotine-free group, but also every time a treatment provider, social worker starts a new earned release program, we created with UW-CTRI a survey where they talk about what kind of nicotine products that they used when they were out, how soon they used it when they got out of bed, how often, when they started, why they started, and then like the last couple of questions, ask them how, if they're where they're releasing to, if they're interested in more information, and then the other, if they are willing, if they want to take our class, which is a 6 session class for an hour once a week, talking about many different things about nicotine, looking at, the biopsychosocial model of the addiction, their support systems, cost benefit analysis of going back to it or staying, quit, kind of looking back at when they started, how they got started, what kind of influences them, and then introducing new coping skills, things like that with them. Um, and then some of the, if they just want materials, usually the most eye-opening thing that I've heard back from the guys that they like is we have this costs of cigarettes that we give them. Um, so it's something I got from
Like
you
a
guys.
calculator?
It's a calculator, the cost of cigarettes. So I usually go on like the beginning of the year to see what the average cost of a pack of cigarettes is in Wisconsin for like 2026. When I Googled it, it was like $10.73. So then you can like look at this calendar. And so if I smoke a pack a day a month, I'm spending $326.59. Or if I've smoked, a pack every day for the last 10 years, I say I spent over 39,000. And just seeing those numbers really kind of opens their eyes. So that's one thing I give them if they want information, along with there's a nice bookmark that I have gotten from you guys that talks of the 1-800 quit now. It's just an easy number for them to remember. Or I give them some resources in their own county where they're releasing to. So
Great. Yeah, that's great. Do you find that people are interested in support to remain tobacco free?
the ones, I mean, we do, like, they volunteer, and even if they're not in group, I have people that will write me and want to take the group. And then some guys get really excited and try to recruit more guys on their units to sign up and everything because they do think it's true. I mean, it's good and it's helpful and it's something more than what we talk about. It's a little bit different than regular groups if you're doing ERP. And it's kind of like the way I tailor mine. It's like the first day we see where everybody's at. What is your nicotine of choice? What do you want out of the group? And then we kind of tailor it to what they want to do. Um, they also contact their significant other or whoever's going to pick them up to talk about, don't bring me that pack of Newports when you come pick me up, or can you refrain from smoking, you know, um, things like that. Although a lot of guys you'll see or they'll write on the survey, well, I'm already quit. So I'm not going to start up. Why would I start now? Because I haven't smoked for 12 years. I haven't smoked for a year. And they don't really look at the whole picture and they just think it's just going to be easy once they get out. And like you said earlier in your presentation, there's so many factors that just easy to fall back into those old coping mechanisms of smoking because they think it's helping them.
Hmm. So I know you've addressed a couple of the things that the men really they found helpful. Any other things that you have found to be helpful to share with individuals as they're leaving facilities to support them in remaining tobacco free?
I just try to get the information to them. I also, kind of I send things out to the other staff, the other treatment providers too, so they
Hmm.
can encourage their men to learn about those things because we're always looking for resources to put in their toolbox to help them when they get out.
Hmm.
Um, I post some things. Um,
Hmm. Yeah, and you mentioned the quit line too.
oh yes, definitely. And then, like you had mentioned earlier too, the other ones. There's also, I don't, did you mention that too? There's also the text ones too. So if somebody doesn't like to call, they can do the text to quit too. And I
Hmm.
think they find that helpful too.
Hmm. Yeah. Well, thanks so much, Carrie. We are going to continue with Q&A, but this is going to be, your questions for me and or, Carrie. So I'm going to stop sharing and we can kind of let me just show my last slides. This is my contact information if you want to reach out to me with any questions afterwards. So any questions that I didn't check the chat as we were going along, but if you have any, feel free to come off mute or drop those in the chat.
While we wait, I have a question. Carrie, this is for you kind of. I'm thinking about reentry, and you are working with your clients in groups and in your programs with, you know, um, coming up with some skills and ways they might be able to quit smoking. But like you said, they're going back to their home environments and they're going to be surrounded with a lot of those triggers, right? Or
Hmm.
feel the need to maybe use tobacco again to cope. And so, is there a way or is there a conversation that you might be having with the probation and parole agents to let them know, hey, your guy who's coming out is really trying to quit smoking? Because I can just speak for myself and our, DCC, I think, that agents try to support the clients coming out when they're re-entering into the community and assist them in ways that they could. So just kind of curious if have been able to have some of those conversations with agents to help kind of bridge that gap from the institution back into their, real lives, if you will.
Yeah, that's a good point. I guess I don't always bring it bring it up. I do put it in because I do their earn release program in their discharge summary that they are interested in being nicotine free, that they've taken the class. Sometimes during agent phone calls when they ask what programs you're in, I'll say, "Well, don't forget about nicotine free group." "Oh yeah, yeah." So, that way that's how I encourage it. I don't always necessarily directly ask, but yeah, we do talk about it, and I do indicate that that is something that they have been working on while they're in here and something that they're hoping to do when they get out.
Nice, thank you. I think most agent would be really appreciative of any of that information, but also any areas like any ways that you think they as the agent might be able to support their client in their
Sure.
efforts too.
Mm-hmm.
So any, suggestions in that to agents, like how they might help support their clients when they come out to be to remain tobacco free. Any thoughts
Yeah.
on that? Like what you would maybe give advice for probation parole agents
Oh,
to
I
assist?
I love that idea. Oh, thought I was talking over somebody. maybe just more education with them and teaching them, what it's about because I think like we both talked about a little bit in the presentation too, we sometimes, not all of us, but I feel people think that tobacco, I'm not going to get revoked. I'm not going to necessarily go back to prison. And we don't look at that's kind of the planted seed that can sometimes lead to bigger things that end up them coming back. So just letting them be known about the resources and communicate, supporting their client, and just giving them those little reminders.
Yeah, and if I could share, like, I think that the quit line as a community resource, I think there's a lot of like, well, I think agents want to be connecting people to resources. I think just connecting them to that resource fits
Hmm.
well within their role, and I think they do want to support people who have this as a goal. So if it's somehow communicated to them, like you said, Carrie, maybe that's the piece that needs a little bit more work, but if that's
Hmm.
somehow communicated to them, then I do think that is a good hat for them to wear is just connecting them to that Quitline resource for support.
Maybe not an appropriate time, but we might want to have Allie or somebody to come to the WCA conference and have a booth so that agents and people in the facility can grab some information and then we can help them with the more resources.
I love that idea.
I do too. I was thinking the same thing just in hearing your presentation. Allie, I was thinking, oh, we could even reach more people at the conference. That's usually well attended, but also in person where you can have some of those things to hand out. So that's a really great idea. I like it.
Awesome. Well, I see we're almost at the end of the hour here, so I really want to just thank everyone for hopping on today, for listening, and if you want to share this recording with others, we'll send out a link to that recording in the next day or two. So I hope you all have a great rest of the day. Thank you so much, Carrie and Teresa for hosting, or Teresa for hosting this, and Carrie for your help with sharing your experiences.
Thank you both as well. I think this was great. And I'm thinking we might try this again sometime. So thanks
Awesome.
so much.
All right.
All right.
Bye.
Bye.
All
Have a
right.
great day.
Too.
You too.